Today we shall review a case of aneurysm coiling using the double microcatheter technique. Case of a 45-year-old male patient who had suffered a grade 1 subarachnoid hemorrhage and was found to have a right middle cerebral artery bifurcation aneurysm. Patient had a ruptured right MCA bifurcation aneurysm. One of the branches was incorporated in the neck, had a lobule near the neck, as can be seen marked by these arrows. We try to enter both the parts, that is the lobules of the aneurysms. We can see in this image that one of the microcatheter is, the tip of the microcatheter is in one of the lobules, and the wire within the other microcatheter is directed towards the other part of the aneurysm. However, this aneurysm was directed in a way that the microcatheter position was not stable, even though the micro wire was going into the other lobules. So we had to take both the microcatheters in one single part of the aneurysm. However, we were able to coil it properly, as we can see later. You can see that one of the markers of the microcatheter is near the fundus of the aneurysm, and the other microcatheter's tip is more proximal in the body of the aneurysm. Start coiling from both the microcatheters. The image A on the left side of the screen has two arrows. The yellow arrow is pointing towards one coil which is smaller in size, and the red arrow is pointing towards a more proximally placed coil which is much larger in size and is supporting the other coil. Typically we make a mesh, and we try to intertwine all the loops so that we have a firm mesh. The initial position of the coils can be variable. They are dependent upon how the aneurysms are oriented and how the microcatheter tip is there, and it gets into your subconscious mind slowly over a period of time. On the right side of the screen is the image B, which is once we have placed couple of coils, and we can see that the coils are going in a way that the pointed part of the aneurysm is still not filled by the coils. So we still have to make some more effort. Coiling progresses. We keep depositing coils one by one in an alternate manner, and we can see that now coils have started to go towards that pouch which was not filling. At some point, one of the microcatheters will be removed. Here we can see on the first image on the left that now we have good amount of coil inside the aneurysm. One of the microcatheter tip is just near the neck, where we have pulled it back to deposit coils near the base, and we have formed a nice base at the aneurysm. The right image on the screen, it's showing some residual filling of the aneurysm. Interstitial filling is there at the neck, which we attempt to fill now. The image on the left still shows two microcatheters, and the image on the right shows one microcatheter has been removed and coil loops are going inside the interstitial filling of the aneurysm, which was seen earlier. We are filling that part of the aneurysm near the neck and the lower body. We repositioned the microcatheter. We can see that the microcatheter has shifted slightly towards the right, and then we deposited some more coils towards the neck. This is the final control angiogram. The aneurysm is completely occluded now. We can still see that the mesh of the coil still will allow some contrast. It is not a very dense mesh. It is occupying most of the aneurysm, but we know that it is going to recur. So this patient definitely needs treatment, as most of these white neck aneurysms will at some point of time. So the patient was consented for stenting at an early date. Patient came, and we deployed one LVIS EVO, which is a poor man's flow diverter, but it works very well in our opinion, especially if the coils have not compacted too much. So we further managed to deposit a couple of more coils in the interstitial, smaller ones. and we have got a very nice reconstruction here. This is the final configuration with which patient lives. We have all the arteries filling, the neck is well what you call reconstructed. The shelf formed by the LVIS EVO was working very well. We can see that the coils are maintaining their shape, their outline. There is a small bunch of coil near the neck which we had deposited at the end, and which was ready to fall, but fortunately we deployed the stent not very delayed manner, and then we have completed the coiling and stenting procedure of this patient in 2 sessions in very short gap. These are some VSO-CT images, not very good quality, but still shows the stent and the coil. We can see the nicely formed shelf, and also it shows how I deploy the stent, which is one limb of the stent, that is the distal limb is longer, the proximal limb in the MCA is shorter, which is my usual practice. One half of the stent I usually will deploy shorter. Usually it will be the proximal one. Occasionally it is the distal limb beyond the aneurysm, depending upon how the branching pattern, how the size forms. This is what I evolved in my practice, evolved over a period of time. So some quick text related to double microcatheter or multi-catheter technique. It is useful in wide neck or lobulated aneurysms, or there is a branch involvement. This technique works very well. It can also be used instead of intrasaccular devices. Nowadays the intrasaccular devices like WEB, RTs, etc. are being used more increasingly worldwide, especially in the ruptured situation. However, if cost constraints are there, which is not uncommon in many developing countries, or there are the aneurysm is lobulated, the lobules are near the neck and cannot be completely well sealed by the device, the aneurysm shape, size, etc. is not appropriate for the device, you can use that. Once you have started getting comfortable with the double system, you can learn different modifications and nuances of how to tackle that. Most of it will come in your subconscious mind as you keep on doing things, and no one can really teach this. There are some techniques obviously, but it's better that you just start it and keep doing it, and then you can combine it with balloons, stent, other devices like Comaneci temporary, the neck remodeling devices, etc. Side wall aneurysms are also amenable to multi-catheter coiling. They are slightly more advanced. People have, or rather, I would say they need some more advanced techniques of the multi-catheter technique, but they do very well. I'm doing that. Chance of aneurysm rupture here with this technique is less than that of balloon-assisted coiling. The balloon-assisted coiling is a standard of care in a ruptured aneurysm treatment. However, it leads to more rupture and also prevents further bleeding once it ruptures, but chance of rupture in with double microcatheter is very low. Chance of thrombus formation, however, is more as you feel more coils at the neck. Some of them can hang down because of the wide neck, and so thrombus does form occasionally, but most of them are resolvable by some type of Ivan fusion or some more heparinization, etc. Most of these patients will not need aspirin for that. Chance of coil loop herniation is obviously there, if you, especially if you have deployed the smaller fine finishing coils at the end, or if the coil mesh has not been formed properly uniformly, like you have been pushing one part of the coil at one and the other coil at the end, one part of the aneurysm, and then they are functioning as different compartments rather than proper mesh. And many of the cases treated with this technique will eventually need stent or clipping, because these aneurysms have originally been complex to start with. So we did a good job at the initial point, and some of these cases will stay occluded, but they will need follow-up, and some of these cases do end up with a second procedure, which is more than what you would achieve by straight away clipping or stent assisted coiling of flow diversion, but the stent associated coiling or FDS in the initial ruptured state is to be avoided in if we can avoid it. So that is why. So basically, instead of using a balloon, which can create some complexity, you can use this multi-catheter technique. You have to use the guide sheath. If you're using only two micro system, like one balloon and one microcatheter or two microcatheter, then any system is okay, any guide catheter is okay. But if you're taking three, then it's preferable to take thicker guide sheaths like blast or even cerebase and similar kind of things, which have a flexible end and they can go up to the petrous region. Keep it high, and you can use three devices also, or at least even if you're using only two microcatheters, it allows you to have a good flush so that you don't have thrombus formation and you don't have poor injection of the DSA runs and all. So end of this double microcatheter simple kind of coiling technique. I hope you enjoyed it. Thank you.